apples with an oranges. It is not heart attack. Although majority of time heart attack leads to sudden cardiac arrest, and that is the most common cause of sudden cardiac arrest. By definition, death or arrest from cardiac cause. Here definition says it is cardiac cause, heralded by abrupt loss of consciousness within 1 hour of onset of an acute change in cardiovascular status. This death has to be natural, rapid and unexpected. This three component has to be there. It has to be natural. Like कोई intervention करती वक्त patient expire है within 1 hour. It is not sudden cardiac arrest. It is not natural death. It has to be natural. It has to be rapid and it has to be unexpected. Pre-existing heart disease may or may not have been known to be present. Exception to this is unwitnessed death, when patient was not seen in last 24 hours. And before 24 hours he was seen in a stable condition, and after 24 hours he was found to be dead. It can be sudden cardiac arrest. It can be labeled as sudden cardiac arrest.
So example आपको DCM 20% EFR patient non patient છે, receive on medication stable છે. If this patient dies, it is a sudden, because we expect a DCM of 20% patient to have VTVF anytime.
Yes, yes.
Right, so this is expected.
Yes.
So this is not sudden cardiac.
No, that is also sudden cardiac, although it is expected. But when it is expected, we don't know. Some in due course of time, anyone is going to die. So death is expected in everyone, all human beings. So, but you don't know that a DCM person will die tomorrow. You don't know when is the onset of arrhythmia is going to be tomorrow, or it is day after tomorrow. So that is also unexpected. DCM is also a common cause of sudden cardiac arrest.
Tricky answer.
Yes, yes. But even book says this. DCM is also common cause. After heart attack, heart failure is a common cause of sudden cardiac arrest.
Of course.
Second common cause.
No, they will rather die with arrhythmia more than.
Yes.
Right, so that.
He can die with arrhythmia, he can die with pump failure, but there has to be some sudden change in hemodynamics or sudden change in cardiovascular status.
Confirm kar do sir.
Yes, yes. This is from Ronak. Even Hurst says so.
Okay.
So what studies say? Studies are a little bit old. 2001 USA. The population considered here was diseased residents more than 35 years with underlying cardiac disease, and the method of certification of sudden cardiac arrest was certificate. So out of total cardiac death, 63% were sudden cardiac arrest. Although this is 2001 data. Then Ireland 2008, nearly 51.5 out of 1 lakh are sudden cardiac death in population. China 41.8 out of 1 lakh. India, the data is again very old, 2012. Verbal autopsy was the method of evaluation, and 10% of total mortality was sudden cardiac arrest. Although Indian data is not that robust data, because verbal autopsy, or you consider death certificate also. Majority of death certificate in rural area or in remote area, they will write sudden cardiac arrest for any cause. Any cause.
Ireland and China were heart patient not.
No, that was population.
Population, sorry.
US was only cardiac patients.
Okay.
India also, it was population disease. There is some in 2021 also there are some data. Even they also considered this death certificate as a method of autopsy. So there also 12% was the sudden cardiac arrest in India.
આપણા દેશ સર્ટિફિકેટ તો કેવા હોય છે?
Everyone had sudden cardiac arrest.
Cardiorespiratory.
Yes. And it is actually in government says you cannot write this as a cause of death. Primary cause of death could not be this. It has to be some disease. So then only we can find out. So that is still a problem. So etiology, there are many etiologies. Commonest etiology is ischemic heart disease. It could be coronary artery disease with myocardial infarction. That is the commonest out of all this. Second is coronary artery embolism. Although it's rare, but post-COVID era, yes, it is common. Non-atherogenic coronary artery disease like arthritis, coronary artery dissections, particularly in females, congenital coronary anomalies can also lead to sudden cardiac arrest. And coronary artery spasm or vasospastic angina or twin metal angina is also one of the causes. Other common causes structural heart disease. These are generally in younger patients, like cardiomyopathy.
Death because of spasms documented, correct?
spasm documented नहीं पण could be it is ascertained that કારણ કે patient survive થાય પછી આપણે angiography કરીએ then you can see that coronaries are normal પણ ઘણીવાર એમાં spasm આપણને દેખાય પણ અને we put nitroglycerin or nicorandil and then it will get relieved. So that is known.
But it can lead to sudden cardiac
It
arrest.
can lead to sudden.
મોટાભાગના આ બધા autopsy finding કે એવું કંઈક કરી શકાય.
Yes, these are either autopsy finding or some minor hints on ECG, echo and then genetic correlation.
પણ ઓટોપ્સી વાળામાં બાયસ શું થઈ જાય કે યુ ડોન્ટ નો ધ કોઝ એન્ડ ઇફેક્ટ.
You know,
બરાબર ને કે એમાં તો કાંઈક ને કાંઈક તો હાર્ટમાં થયું
that
હશે.
could be incidental finding.
એક્ઝેક્ટલી રાઈટ. એટલે પણ આ તો આપણે તો ટેવ છે કે લખી નાખીએ પછી.
So structural heart disease like cardiomyopathy, hypertrophic cardiomyopathy common in patient aged less than 35 years of age. Dilated cardiomyopathy, rarely ARVD also, arrhythmogenic right ventricular dysplasia. Not very rare, although it's a rarely diagnosed, but it's common disease. Then valvular heart disease, like congenital aortic stenosis or congenital mitral stenosis, can also lead to sudden cardiac arrest. Congenital heart disease, particularly cyanotic complex congenital heart disease, myocarditis, acute cardiac tamponade, acute myocardial rupture, generally it is secondary to myocardial infarction, and aortic dissection are some of the structural cardiac diseases. Then electrical disease like Brugada syndrome, long QT syndrome, these are two are common. Complete heart block is also common, although complete heart block generally post ischemia is more common than degenerative complete heart blocks or familial complete heart blocks. Then sometimes unknown cause, familial sudden cardiac death is also known cause. There could be the cause of CPVT could be one of the cause in that familial SC. Commotiocarditis is again it's a ventricular arrhythmia post chest trauma, blunt chest trauma. Then idiopathic VTs. And then fourth category, which is not included by definition in sudden cardiac death, but are non-cardiac causes, which can lead to sudden death. It is not called sudden cardiac death, or it can cause sudden arrest. Are pulmonary embolism, intracranial hemorrhage, drowning, some drug-induced. Drug-induced could be non-cardiac also, drug-induced could be cardiac also. Central airway obstruction and sudden infant death syndrome. So if you look at percentage-wise, 60 to 70% is ischemic heart, significantly less in less than 40 years. Less than 40 years, the common is structural heart, which is overall 10 to 20% of the sudden cardiac arrest, and 5 to 10% is non-structural heart disease. This is not considered in sudden cardiac arrest because it's not cardiac. Here, the special consideration is sudden cardiac death accounts for 30 to 50% death in patient with heart failure. So heart failure again is very common cause of sudden cardiac arrest. Risk of both arrhythmic, non-arrhythmic death can be reduced by chronic heart failure therapy. So it is curable and it is preventable. But still it is remain high because generally our patients are not getting adequately treated for heart failure as per guidelines. So any drugs like beta blockers, ACE inhibitors, ARBs, even this sacubitril valsartan reduces sudden cardiac arrest in chronic heart failure patients. Important to know causes are which are transient and reversible. First is obviously acute MI, which is reversible and can be treated easily. Antiarrhythmic drugs, because these antiarrhythmic drugs lead to prolonged QT and it can lead to arrhythmia. Antiarrhythmic drugs can promote arrhythmias. So that is also one of the commonest cause. Medications like QT prolonging drugs, toxins or illicit drug use can also lead to sudden cardiac arrest. Rarely electrolyte imbalance, per se electrolyte imbalance is not going to cause sudden cardiac arrest. But electrolyte imbalance in background of diseased myocardium or diseased substrate like hypokalemia or hypomagnesemia, particularly in a case of acute ischemia, can lead to sudden cardiac arrest. Per se direct hypokalemia is not going to lead to sudden cardiac arrest commonly. Heart failure, here treatment with adequately drugs can reduce risk of sudden cardiac death. So these things are common to know. These are common causes and can be prevented.
રોનક એક કન્ફ્યુઝન છે
હમ.
વાક્ય બોલું છું સાચું ખોટું કે છે સડન કાર્ડિયક અરેસ્ટ is primarily cessation or abnormality of the electrical activity only. Is it correct or wrong?
No, no, it is both electrical activity and it has to be changed in cardiovascular status like
Of course,
hypertension.
it will follow, but it is primary electrical activity which leads to everything.
You can say that, yes, it's possible.
Then you cannot use SCA and SCD interchangeably here.
SCD is the end. SCD
ના
is
તું
the
આ
end.
છેલ્લી સ્લાઇડ બોલ્યો ને એમાં તું
હા.
એક બે વાર SCA બોલ્યો
હા,
SCD
એટલે
is rarely used interchange. It cannot be used.
it cannot be used.
So this is SCD. This can lead to SCD.
Yes, so
Before SCD, there should be SCA.
Yeah.
Incomplete SCA.
so here causes of SCD it may be other than SCA.
Yes.
Okay.
Yes. Right. So this is the approach. How should we approach the survivor of sudden cardiac arrest? We are not going to discuss how to survive because that's a CPR and absolutely separate entity. So we are not going to discuss that. First, commonest thing is history and examination. So that is part of initial evaluation. That will include lab investigation. That will include ECG. And after that comes specialized investigation based on initial evaluation. That could be coronary angiography. That could be echo or cardiac MRI. That could be EP study or that could be any other genetic testing. So let's go to first initial evaluation. It begins immediately after resuscitation. The first concern here is to identify and treat the reversible causes, what we discussed. History and examination will give us about, it should include prior history of any cardiac disease or any other disease or any drug used in past. It should include use of any illicit drugs or toxins. And it should include antecedent symptoms, as we discussed that prodrome symptoms could be there prior to the sudden cardiac arrest event. Prodrome could be there before prior to month also. So any ischemic symptoms in prior month or prior year also, that can also give us clue about possible cause of sudden cardiac arrest. But the limitation here is post resuscitation initially, patient can have retrograde amnesia because of loss of cerebral perforation for time. So that is one of the limitation of initial history and evaluation. Then metabolic investigations can help us sometimes, like magnesium, hypomagnesemia in background of some cardiac event can suggest myocardial infarction, hypomagnesemia leading to ventricular arrhythmias. Hypocalcemia again, hyperkalemia can lead to sudden cardiac arrest, but there has to be some background of either cardiac or renal etiologies. Then there comes limitations of lab investigations. Now there is sudden cardiac arrest, so there has to be some loss of circulation. This loss of circulation can lead to lactic acidosis. It can lead to hypokalemia or hyperkalemia also sometimes. So this hypoperfusion can lead to electrolyte abnormality. So this has to be taken as a pinch of salt. Whether it has been caused by sudden cardiac arrest or whether it is the cause of sudden cardiac arrest, that needs to be differentiated and their clinical acumen can help us. Resting ECG. It can reveal definitely, it is going to reveal about ongoing ischemia or prior myocardial infarction. Conduction system abnormality can also be ascertained from resting ECG, like bradyarrhythmias, second degree heart block, complete heart block, some bundle branch block. Brugada syndrome, long QT syndrome, WBW syndrome can also be ascertained on resting ECG only. Very rarely hypertrophic cardiomyopathy in ARVD can be picked up on resting ECG.
now LV dysplasia નામની ટર્મિનોલોજી છે એરિથ્મોજેનિક LV dysplasia
It's both actually. Arrhythmogenic, not LV, it's a misprint, it's RV dysplasia. LV dysplasia is there, but it's very rare, very rare. Then comes the specialized investigation, that is step number 2, 3 and 4. Why coronary angiography came first? Because myocardial infarction is the common cause. So for ACS patient, the data says that sudden cardiac arrest during first 48 hours after STEMI have higher in hospital mortality. Second, STEMI with sudden cardiac arrest should undergo urgent PCI. As we all know, STEMI has to undergo urgent PCI. And even end-STEMI, urgent PCI is also recommended for confirmed end-STEMI or suspected end-STEMI presenting with sudden cardiac arrest. These are for ACS. For diagnostic purpose, patient with either stable angina or patient does not have any history, ECG is normal, patient presenting with sudden cardiac arrest, there also angiography is recommended to rule out stable ischemic or stable chronic CAD. Why? Because even chronic CAD, even if it is stable angina, can lead to scar formation and it can give rise to monomorphic ventricular tachycardia. It can give rise to sudden cardiac arrest. So when other causes are not found, angiography is recommended even in patient with stable angina or even in patient without any angina. But generally in young
Is
patients,
it always possible to rule out stable angina with angiography?
no. It's just to rule out, just to confirm that there is no coronary artery plaques or no stable coronary artery.
એક સિચ્યુએશન આપું હું કે સપોઝ સબ સેન્ટરમાં એક્યુટ કોરોનરી એસટી એલિવેશન થ્રોમ્બોલાઇઝ કર્યું છે કોઈ ફિઝિશિયને આઈસીયુમાં and after thrombolysis change is reversed, patient also becomes symptomatic fine, vitals are okay, but thrombolyze કર્યાના within 1 hour એટલે essentially presentation ના 2 કલાકની અંદર patient has sustained VT અને it revert with shock અને anti-arrhythmic. Will you rush this patient for angio?
Actually, no, that depends. After post-VT, if the ECG is not showing ST elevation, then there is no need to rush for angio. Because angiography is not.
Dynamic, કારણ કે હજી just હમણાં
Yes, that VT could be reperfusion. Because within
Exactly.
1 hour of this.
So આમાં જે આ statement છે કે STEMI with SCS would undergo urgent PCI. બરોબર છે તો
This is not thrombolized. Directly presented to cardiac center.
okay, then it's a different. Oh, yeah. Okay.
These are indications for angiography.
Okay, I mean,
Patient present to peripheral center thrombolized.
Okay.
As if it is successful
So those physicians
thrombolysis.
who are thrombolizing may get this type of કે ભાઈ આવું થયું અને પછી VT થયું એટલે આ એન્જિયોમાં ભગાડ્યા એવું
No, definitely no. VT, it has to be reperfusion arrhythmias,
Exactly.
easily treatable with Zylog and Zylocard infusion. So start Zylocard infusion, VT will subset. And very rarely what happens is non-sustained VTs or slow VTs, it can get reverted to atropine. So when heart rate is somewhere around 90 and patient is showing broad complex QRS, PQRS
something
dissociation
called
is there.
AIVR.
Yes, AIVR. Give atropine, it will revert. Increase atrial
Many
rate.
time atropine is also not needed in AIVR.
Yes. AIVR per se does not need any treatment, but majority of time VR overcautious is
Yes,
AIVR
of
can
course.
degenerate into VTVM. So give atropine, it will revert.
Actually thrombolyze તમે કોઈ બી જગ્યાએ કરી by whatever means તમે ઇન્ડિકેશન થઈ કે એન્જિયોગ્રાફી કરી છે તો વહેલામાં વહેલી ક્યારે કરી છે
After 3 years, successful thrombolysis with
whatever it may be successful successful by તો કોઈ
successful તો
કરવાનું
generally
નથી.
elective angiography, unsuccessful
પણ
તો
અનસક્સેસફુલ હોય કે બીજી કોઈ બી જરૂર પડી તમને એન્જિયોગ્રાફી કરવી જ છે તો વહેલામાં વહેલી ક્યારે કરી છે
something there. Within 1 hour also we can do.
હા.
But there we have to prefer radial route because patient is already been thrombolized. If you prefer femoral route, then it can lead to femoral hematoma. So radial hematomas can be easily managed. So preferably go radial post thrombolysis. At least up to 6 hours.
આવું કંઈક કહેવાય છે ને
So that is pharmacoinvasive. Pharmacoinvasive was this was invented when patient was being transferred from periphery to the center.
એમ્બ્યુલન્સમાં બોલસ આપી દેવા
Yes, so they give thrombolysis in ambulance. If it reverts, angiography on next day, elective angiography after 24 hours. If not reverted, within 3 hours also you can go for angiography. That is pharmacoinvasive. And in young patients without any identifiable cause, CAG may reveal anomalous coronary artery disease. Very rarely it happens that left main is of anomalous origin and left main ostium is slit-like. So that will lead to hypoperfusion of heart. Or sometimes in Kawasaki disease there are aneurysmal coronary arteries that can also lead to myocardial ischemia and sudden cardiac arrest. So in patient where any other cause is not found, angiography is again necessary. May it be CT angiography, it is not always conventional. May it be CT. Young patient CT angiography is an option. But beyond 40 years again, calcium scoring has to be done prior to CT angiography, then go for CT angiography.
less likelihood of positive result CT angio would
CT
be better.
angiography is fair enough. For less than 40 years it is good. And CAG is not necessary, only where other identifiable causes there. Evaluation for other structural heart disease. Generally, this is done prior to coronary angiography. 2D echo and color Doppler. 2D echo will suggest or confirm the diagnosis of coronary artery disease in form of valvular dysfunction and regional wall motion abnormalities. It can confirm easily the diagnosis of hypertrophic cardiomyopathy, dilated cardiomyopathy, aortic stenosis, and even ARVD also can be diagnosed on echo. Some other structural abnormalities are also there that can be found, like mitral prolapse can also be found on echo, and very rarely non-convection cardiomyopathy can also be found on echo. So these are the use of echo in sudden cardiac arrest survivors. The limitation here is whenever there is cardiac arrest, CPR was given, multiple drugs has been given. This event can lead to transient myocardial suppression. So that can be misdiagnosed as cardiomyopathy because of myocardial stent. So echo has to be repeated after 48 hours whenever there is regional wall motion or whenever there is a dilated cardiomyopathy or whenever there is some abnormal findings. Echo has to be repeated after 48 hours and compare. Like we compare ECG after every 1 hour in myocardial infarction. Echo has to be repeated in 48
What
hours.
are the conditions where you will have RWMA just because of arrest, not because of coronary?
RWM is very rare. Global hypokinesia is common. RWM is very rare, but particularly in case of vasospastic angina, there could be transient RWM. That is possible. Or even in case of stable coronary artery disease, whenever there is a significant lesion, 80%, temporarily because of hypoperfusion, that area can show RWM, which will improve over a period of time with circulatory improvement. Cardiac MRI is done in case to ascertain diagnosis in spite of above mentioned evaluations are ARVD, myocarditis, and some infiltrative cardiomyopathies like amyloidosis and sarcoidosis. Even amyloidosis and sarcoidosis SC is very common. There are some studies where all sarcoidosis patients or cardiac sarcoidosis, the number of sudden cardiac arrests were 67% in sarcoidosis, and in cardiac amyloidosis it was 34%. So patient with cardiac amyloidosis and sarcoidosis have very high chances of death because of sudden cardiac arrest. That is common. Then there is some electrophysiological studies. It's not very commonly being done. It's not recommended also by guidelines. But all the books mention this to certain extent to find out apparently normal structural heart disease. The cause of sudden cardiac arrest here could be abnormality in ion channels like Rugada syndrome, long QT, short QT syndrome, and CPVT. And not due to ion channel abnormalities are WPW and commercial. This, out of this, Rugada can be ascertained on ECG only, LQT on ECG, CPVT if ECG is taken during ventricular tachycardia because it generally is bidirectional VT. That is very classical ECG where EP is not recommended. WPW syndrome can also be found on ECG. Short QT can also be found on ECG, but these are transiently found on ECG. If ECG did not show anything, coronary angiography comes normal, all other investigations normal, all other causes are ruled out, then electrophysiology study is recommended in this case.
Most of the time, these are either family history of sudden cardiac death,
There has to be some family
or
history.
they are the gyming person,
Yes.
person who are going to the gym,
Yes.
or person who are attending the
Or athletes like
and,
football or
and the third thing is the gaming zones.
possible, yes.
See, where the young person suddenly develop cardiac arrest
Yes.
out of
Right.
sympathetic overactivity or maybe whatever in that.
Right.
So you have a scenario for this kind of thing.
Yes. So that comes in history. History will tell us about what is the possible cause. Like in more than 35 years, you keep coronary artery disease as the first cause. Less than 35, you will keep arrhythmia and structural heart disease as the common causes.
Recently that TV actor also died during living.
Many people, I think post-COVID or even pre-COVID also, many people died suddenly because of and young people, athletic, not obese, sudden death.
I guess illicit drug use, that is also.
Yes, that is one of the only common factor in all this.
Yes.
So, EP studies can tell us about abnormality of AV conductions, like in terms of bradyarrhythmia. It can also find out SSI pathways, WPW syndrome. Now, the common WPW syndrome
Will you
for
go
say
for EP study first or will you go for that 24-hour or 7?
Halter.
Halter mode, I think.
Halter first. Here, halter is also not required because patient is in hospital. sudden cardiac arrest patient is going to stay in ICU for 24 hours. So ICU you monitor, or that is not required. Until unless you keep patient in ward, but that is generally not done. Sudden cardiac arrest survivor will stay in ICU for 48 hours at least. So per se WPW syndrome is not going to lead to sudden cardiac arrest until and unless there is atrial fibrillation, which can lead to ventricular fibrillation because of conduction over accessory pathway. Otherwise, WPW syndrome will lead to supraventricular arrhythmias that is not that life-threatening as compared to atrial fibrillation in WPW syndrome patients. Then inducible ventricular arrhythmias like LVOT arrhythmias, RVOT arrhythmias in structurally normal heart patient that can be ascertained on EP study. Myocardial scar mapping that is done with 3D mapping on EP studies that can also be ascertained on electrophysiology study. And very rarely supraventricular arrhythmias can also be found on EP studies, and that is easily treatable in form of RF ablations. We are not going into limitation because that is too technical details. Exercise testing is not required routinely, but it can help us diagnosing long QT syndrome and CPVT arrhythmias. Ambulatory monitoring or 24-hour monitor, it is done only in patient without any clear etiology of sudden cardiac arrest in spite of all evaluations. And we can give pharmacological challenge, like when you are suspecting Brugada syndrome. So you can give procainamide for induction of Brugada syndrome. Epinephrine can be given for induction of catecholinergic polymorphic VT. It is also very rarely done. It is also required when other causes are ruled out. And then comes the idiopathic PF without any evidence of structural or electrical abnormality evaluation. So there certain cases still remain in spite of all this battery of investigations that can be termed as idiopathic ventricular fibrillations. And minor cardiac abnormalities, which is more or less compatible with idiopathic PF type of cases, are not clear causal relations, and the commonest cause of this are first degree heart block, transient second degree heart block which is not detected on ECG, isolated bundle branch blocks like LVBB, RVBB, thickening of LV free wall or septum, but not in the territory of hypertrophic cardiomyopathy, which is less than 10% of normal thickening. That can also be sometimes early hypertrophic cardiomyopathy. Then hypertension without LV hypertrophy could be also one of the marker of giving such minor cardiac abnormalities. MVP, paroxysmal or persistent AF and isolated ventricular premature beats. This could be the marker of minor cardiac abnormalities. Then family screening is recommended for patients who are diagnosed with long QT syndrome, hypertrophic cardiomyopathy, Brugada syndrome, ARVD and CPV. This patient will require familial screening also. Then this is also a very vast topic which is covered only in one slide, neurological and psychological assessment. Psychological assessment we are not going to discuss because this is again a separate topic, because many times this patient post-traumatic stress disorder is very common. So psychological evaluation has to be done and psychiatrist has to be involved, which is not possible in India as always, but yes, this is recommended. And neurological evaluation has to be done to establish the extent of impairment resulting from cardiac arrest. It has to be physical examination, history as well as imaging. Signs of poor outcome here is absence of pupillary reflex beyond 24 hours, absence of corneal reflex beyond 24 hours, and absence of motor response to pain more than 24 hours, and absence of this is sensory response to pain 72 hours. So to summarize everything, what is mandatory? Detailed clinical history including information on drug intake is mandatory. Blood chemistry in terms of cardiac enzymes, thyroid function test, alcohol level or toxicology screening, inflammatory indices, electrolytes are must, ECG is must, echo is must, even angiography is must for patients above 35 years of age. EP studies must only if all this comes normal. What is recommended other things which is not mandatory is urine test for toxicology and electively very rarely signal level BC, which is a newer marker of minor cardiac abnormality, can be done but which is not available as of now. Baroreflex sensitivity in terms of tilt table testing.
સિગ્નલ એવરેજ ECG એટલે થાય છે.
એક સિગ્નલ એવરેજ ECG એટલે ECG ની આપણે જે સ્ટ્રીપ કાઢીએ એનો મેગ્નિફાઈડ વ્યૂ હોય જેમાં QRS complexes પછી there are minor electrical abnormalities are there that suggests that there is some repolarization abnormality and that can indicate arrhythmias. Even in normal ECG machine that can be done, but that has to be some separate software on that machine. So that is signal average ECG.
Can it lead to some course finding as well? કારણ કે post arrest વાળું
It's there since when I was studying 2015. It is there since 2015. But till now, no major studies, no guidance recommended this.
health advantage.
Then on Holter, even heart rate variability can give some clue about tachycardia arrhythmias. Genetic testing is not compulsory, but it should be done in patients with genetic cardiomyopathies or cardiomyopathies. Then ergonomic test when spasm is suspected in coronary artery disease. And EPS programmed electrical stimulation can be done, it depends on electrophysiology. And very rarely ventricular biopsy to rule out infiltrative cardiomyopathies can be done. But these are not compulsory, these are the common tests to be done followed by